as low as 18% to as high as 46.2% in the studies which have been done on hypertension in the past few years. So the high prevalence, lack of awareness, lack of treatment, lack of control in Pakistan has been documented in the literature. It has been studied in a study which was published in British Journal of General Practice in 2010, that there are about 20 million hypertensive in Pakistan. Out of these 20 million, 16 million people are untreated. And if I do the breakup of this 16 million, 12 million do not know that they have hypertension. Only 4 million know, but still they are not being treated. And if we look at the treated group, which is the remaining 4 million out of 20 million, 2 million are treated, but they are not controlled. And only out of 20 million, 2 million people are receiving treatment and they are controlled according to the guidelines as well. So 20 million people, which are projected to be 30 million by 2025, making 33% of Pakistani population above the age of 45 being hypertensive. Number one contributor to both mortality, leading to 200,000 deaths per year, and at the topmost reason for strokes, like 350,000 stroke incidents per year. And still, hypertension is not addressed by the masses. We know that almost 1 out of 10 of hypertensive patients are not adherent to their treatment. And if they are not adherent to their treatment, obviously they are not controlled. And when your blood pressure is not controlled, it can affect every single organ of your body, starting from your eyes to your heart, to your kidney damage, and you name it. And hypertension has an adverse effect on that system. Another study from 2016, which was the report of National Health Survey of Pakistan, it showed that hypertension affects 18% of the adults. And if we take the age bracket of 45 years and above, 33% of adults, they suffer from hypertension. And if we bifurcate it according to the different provincial categories or regional level, then Balochis, Pashtuns, Muhajirs, Punjabis, and Sindhis, they have almost similar demographics, except in Balochis, where it was seen more prevalent in female population. Another study which was published in 2016 and 17, this was basically the National Diabetes Survey of Pakistan. It was a big study, but it also looked at the prevalence of the contributing risk factor for hypertension in urban and rural areas of Pakistan. This was done by the BIDE group, Dr. Abdul Basit, and they showed that the overall prevalence of hypertension in Pakistan was 46.2%, which is a very, very high figure, of which 24.9% had self-reported hypertension, 21.3% were newly diagnosed hypertensive, and there were some differences in the urban and the rural areas, in which both areas the prevalence was very high. In the urban, it was reported to be 44.3%. And in rural areas, it was even higher, with 46.8% people suffering from hypertension. The highest rated prevalence was seen in the most populated province of Pakistan, which is Punjab, which accounts for about 49.2% prevalence of hypertension, followed by Sindh, 46.3%, and then Balochistan and Khyber Pakhtunkhwa. It was also noticed that hypertension was more prevalent in rural compared to the urban areas, except in Khyber Pakhtunkhwa, where it was more prevalent in the urban areas. Another study from 2017, which was a survey of hypertension prevalence, awareness, and treatment, which was published in the Journal of Epidemiology and Global Health. And it showed that although there is a limited updated information on the prevalence of hypertension in Pakistani population, but this cross-sectional study, which was conducted in rural centers of Punjab in Pakistan during the period of 2008 and 2015, showed that there was an overall crude prevalence of 35.1% and age standardized prevalence of about 34.4% of hypertension in Pakistan. Another study, which is from the Archives of Public Health, in 2018 it was published, and it shows that the overall pooled prevalence of hypertension was 26.34%, and the high burden of hypertension among the adult Pakistanis when compared to the data which is published in local and international journals. So these are some of the major big studies related to hypertension that I could find on the literature search. If this study has the sub-analysis I share with you of this study, which was published in 2018, the subgroup analysis showed that the urban prevalence of hypertension was 26.61%, whereas the rural prevalence was 26.03%. If we look at the previous years and the rate of growth of hypertensive or prevalence, increase in the prevalence of hypertension in the last few years and in the coming few years, it is seen that with every passing decade, there is a significant rise in the number of hypertensive patients, which started as 19.55% in 1990s, jumped to 23.95% in 2000, and in 2010s, it is 29.95%. And it is predicted that there will be an increase in the by 2025 and 2030. If we look at the gender-wise prevalence, we always associate hypertension and cardiovascular disease with the male pattern. But this study showed that males and females are almost equally affected by hypertension, and male account for about 24.99%, and females also 24.76% are suffering from hypertension. So what are the determinants of hypertension? Why do we have such high prevalence of hypertension in our part of the world? So social determinants are broadly defined as the circumstances in which people live, they are born, they grow, they work, and the systems put in place to deal with the illness. And there are three main components of these social determinants. That is environment, genetics, and epigenetics. And if we look at this, they are somewhat different from the rest of the world. Therefore, the prevalence studies had to be done on the local area to find out what are the specific social determinants which lead to hypertension in Pakistan. So just summarizing and giving you an overview of hypertension, the disease, the global prevalence, we know that 31% of total global deaths, they result from the various forms of cardiovascular disease. And about 7.5 million deaths every year are reported due to hypertension or high blood pressure. And we also know that the risk of cardiovascular disease doubles for each an increment of 20 millimeters of systolic and 10 millimeters of diastolic of blood pressure. So high blood pressure remains the #1 cause of cardiovascular disease, contributing to morbidity and mortality related to it. We also know that hypertension is a major cause of premature death worldwide, and the global targets for premature deaths and hypertension is that 25% reduction in premature mortality and 25% reduction in raised blood pressure by year 2025. So these are the targets for the non-communicable diseases by World Health Organization. And we also know that if we can control blood pressure, we can significantly reduce the risk for cardiovascular disease and events and all-cause mortality. And it has been documented in studies that adults who are hypertensive, if we control their blood pressure to a non-hypertensive level, either through non-pharmacological interventions or pharmacological treatment, then we can reduce the risk of cardiovascular events by as high as 20 to 40%. So such a huge benefit can be obtained just by controlling the blood pressure of these patients. So I would like to give my message in the end to everybody who is attending this course with the request to spread this message of awareness to all their questions, that know your numbers, find out what your blood pressure is like, get yourself tested for high blood pressure. When you know your number, only then you can take treatment and then control your blood pressure. So these are the two things that I want to emphasize. Know what are your numbers, whether you fall in the category of a normal blood pressure, that is 120/80, or if it is above this, what is your blood pressure levels, because we know that as the blood pressure rises, the cardiovascular and mortality increases your risk of dying, and you can minimize that risk by healthy food, exercise, and meditation. So with this, I would like to thank you all. If you have any feedback or questions, we will be here at the end of the session. But you can also write to me, and here is my email address. Thank you very much for your patient listening.
I think it's very important to realize how big a burden hypertension is to our community. I would be inviting our second presenter for today. Our second topic for today is diagnosis and initial evaluation of hypertension. It is to be presented by Professor Azizur Rahman. Previously, he was at Services Institute of Medical Sciences, and currently he's serving as Professor of Medicine at Rashid Latif Medical College, Lahore. He's also the Senior Vice President of Pakistan Society of Internal Medicine and the Editor-Journal of Pakistan Society of Internal Medicine. Former editor-in-chief of Esculapio, the official journal of Services Institute of Medical Sciences, and his main areas of interest include diabetes, hypertension, and chronic hepatitis. Sir, as we already spoke, he's also the program coordinator for this certification program. Sir, thank you very much for organizing this, and also you may take over for your presentation.
Okay. So
yeah, thank you, sir. Okay.
Muted. First of all, let me thank my first speaker, Dr. Somia, for a brilliant talk and finishing on the dot. So I think we will try to continue this tradition and finish the program well in time. So my topic is initial evaluation, profile, and also I have added this later, profile of different available choices. So this is the 2-point agenda. First of all, let's take initial evaluation. We have different tools for evaluation. First of all, the first step is accurate measurement of blood pressure. And I will talk in some more detail later in the part of presentation, but first component, of course, is the accurate measurement, because the diagnosis of hypertension is based on accurate measurement. It does not require any investigation for the confirmation of the diagnosis. And second thing is a focused medical history. Of course, patient may have multiple issues, but when we evaluate a case of hypertension, we must ask everything related to hypertension, which will point toward the etiology and will also point toward any possible end organ damage, any other factor which may affect the treatment plan. Then we have very focused physical examination. Of course, that means you have to measure blood pressure not only once, more than once, maybe in 2 arms, maybe in the leg also, and then some selective tests. Everybody may not need all the tests. In some cases, it may be just appropriate to take the blood pressure reading and start with the treatment. And some other cases, it may be more appropriate to go for the test and make a final diagnosis to rule out certain secondary causes and then start the treatment. So these are the tools we have. And the overall plan is, first of all, measurement of blood pressure. Gold standard is mercury, but mercury has certain hazards, so it is disappearing from the world. But aneroid, if calibrated properly and in good condition, is equally accurate. And digital is very convenient. These days, it is highly recommended that digital should be used because it is very easy for the patient to use it. I think many international studies have been conducted using digital apparatuses. They are validated now. Now, in the first evaluation, blood pressure should be taken in both arms. And the lower reading, the higher reading is the actual blood pressure, if there is significant difference. And in some cases, depending upon the facilities available, the home blood pressure monitoring and ambulatory blood pressure monitoring may be required. And the second thing is some basic labs. I think urinalysis, urine examination is a simple, cheap test available everywhere. So this should be done. Some proteinuria, some CAS, some RBCs will give you a very important clue. Creatinine should be measured, not only just creatinine. I think we should try to calculate the GFR, and calculators are available on handheld devices and on the net. So I think at the initial evaluation, we must determine the creatinine clearance, the eGFR. Electrolytes are important. For example, hypokalemia in a person who is not on diuretic suggests some conditions. Then ECG may show left ventricular hypertrophy. If that is the case, that would indicate that there is some urgency in starting treatment. We are already late, and that is in itself a morbid condition. Ultrasound of abdomen is great because it tells you a lot of information regarding hypertension, especially kidneys and adrenals. Then some other tests as needed. Then third objective of evaluation is to see if blood pressure has silently caused some damage. We call them hypertension-mediated organ damage. Some damages can be actually seen. For example, fundoscopic examination can reveal if there is hypertensive retinopathy. Left ventricular hypertrophy can be picked up clinically or some on ECG. That would indicate that there is some organ damage already there. So the most vulnerable organs should be evaluated, like heart, brain, and kidneys and eyes. Echocardiography is very useful, maybe limited echocardiography. I've seen many patients who are still unconvinced that they're hypertensive and they have not yet started treatment. And if you do echo, you will see some hypertrophy or some diastolic dysfunction. I use this point as a convincing point that to tell the patient that this is not the transient elevation. You already have problem with your heart. So that is, I think, indicator of starting treatment. Then in secondary causes, most causes are related to kidneys or adrenals. And also hypertension can cause kidney damage. So I think kidney needs to be examined in great detail, and adrenals and others. And there are some exacerbators. They are not the actually causes. For example, massive drinking, smoking, certain drugs, some very commonly used drugs like non-steroidal anti-inflammatory drugs and many immunosuppressant drugs, they can cause hypertension, or they can at least contribute to hypertension. So in a given patient, we'll see if any of these drugs can be removed, and patient may not then need antihypertensive treatment. And then I think we must examine the patient as a whole. We must take detailed history and see if the patient has got diabetes or has got ischemic heart disease or has got COPD, asthma. These conditions will help choose the right agent. You know, certain agents, for example, beta blockers are not right for asthmatic patients. Some drugs are particularly useful for those who have ischemic heart disease. So I think we need to see the patient as a whole. Out of this, I think I'll go to this little more detail, the measurement of blood pressure. Now, International Society of Hypertension has released this picture. Now, this picture gives you a lot of information. And I'm not sure if you can read this fine print. Number one, I think it is that instrument should be calibrated. Patient should be physically, mentally relaxed. The environment should be comfortable. And you should take 3 to 5 readings after 3 to 4 readings after an interval of about 3 minutes rest, and then an interval between different readings 1 minute. Patient can do it himself. Patient must be sitting comfortably with legs on the feet on the resting on the floor, back also resting, cuff applied to the part of arm which is at heart level. And all these required. Patient should not be talking when blood pressure is taken. And I think what I do is I tell my patient to literally meditate when blood pressure is checked. And that way you can have an accurate reading. So if you take 3 readings, 1 minute apart, you can take average of second and third, that will be your blood pressure. And patient should be encouraged to take his reading at home, because home readings are more reliable and they correlate with morbidity and mortality better. Now, further tests would depend what we find on initial evaluation. For example, patient with hypokalemia would need a certain investigation. I'm sure my colleagues tomorrow, Professor Azazman will cover this part. and Professor Imran Hassan also will cover this part, urinary sediments and kidney asymmetry. So I think whatever problem we find in the initial evaluation, that is then followed it up. The philosophy is that initially we do simple tests which are available, which are not expensive. So we have some idea if patient needs further detailed investigations. Now, every patient at the time of diagnosis is not the same. Hypertension is a dynamic disease. Somebody who has just stage 1 hypertension with no additional risk factors, he and another person who has stage 3 hypertension with multiple risk factors or existing diabetes or existing cardiovascular disease, these two patients have altogether different phenotype and they have different prognosis. So they have to be handled differently. For example, this patient would require combination treatment to start with and would require rapid follow-up. Now, this was the agenda item number 1. The second agenda is because Professor Shahbaz Qureshi is going to tell us the treatment algorithms. I just thought he may not be able to go into the details of every agent we have. So I'm going to just give you, especially our younger lots, a just brief intro of various antihypertensive agents and their profiles. And aim is not to decide which one is the best. The aim is to decide which one is the best for the given individual. So that is the whole art of medicine. So second agenda item, profile of different antihypertensive. We have very popular group angiotensin converting enzyme inhibitors. The mode of action is apparent from the name. It prevents conversion of angiotensin 1 into angiotensin 2, which is a potent vasoconstrictor. And we have several examples, captopril, lisinopril, enalapril, and perindopril. And every medicine has the upper side and the downside. And the angiotensin converting enzyme inhibitors, they are very well tolerated, generally speaking. And besides controlling blood pressure, they offer cardiovascular and renovascular protection, and they are very useful in heart failure. So I think in the start, if somebody has heart failure, I think the choice should go to this group of drug. Then the downside, it is very notorious to cause dry cough. We do not know the exact prevalence in Pakistan, but estimates are from as low as 7% to as high as 25%. So this is a very, very annoying symptom. So many patients, they stop because of the cough, and many physicians don't want to start because of this cough. Then angioedema could be serious, and these drugs are contraindicated in pregnancy. Another class, angiotensin receptor blockers, losartan, valsartan, olmesartan, and telmisartan, they block the ultimate effect of angiotensin 2. And the advantages, the good side is that they're well tolerated. They have, again, cardiovascular, renovascular protection, at least equivalent to ACE inhibitors, and they're useful in heart failure also. And the downside is very small. They are somewhat expensive compared to some other agents, and they are, again, contraindicated in pregnancy. Because of the fact that these drugs do not cause cough, so whenever we want to prescribe RAS blocker, generally we tend to prescribe these ARBs, but of course, some people, they are very fond of angiotensin converting inhibitor, they still prescribe it, they are great drugs. And third is calcium channel blocking agents. So this slide got dislodged, and I think the good side of calcium channel blocking agent is that they are quite cheap and broad spectrum effect, and they are metabolically neutral, no much problem metabolically. But the downside is that they may cause edema, and some of amlodipine is, for example, very notorious to cause edema, especially when we go to 10 milligram and beyond, and they may cause constipation, they may cause bradycardia also. Now, and one additional advantage is that they have anti-ischemic properties also. Okay, so moving on to the next group, beta blockers, very old drugs. We have propranolol, atenolol, metoprolol, bisoprolol, and a newer generation beta blocker, nebivolol. And the good side is they're very economical. Many physicians, they still use them. Antiarrhythmic drugs, especially in patients with ischemic heart disease, anti-ischemic effect and sympatholytic effect. There are some young people who are very, very nervous. They have palpitation, they have anxiety, they have tremor. I think this may make a good choice for them. And they can be prescribed in addition to other drugs. And the side effects are lethargy, erectile dysfunction, minus nebivolol. And there are reports that nebivolol may actually improve one's erectile dysfunction. Asthma, no proven benefit on stroke, and they may cause dysglycemia. And they may increase onset of new diabetes. Alpha blockers, generally we don't use alpha blockers for hypertension, but in some refractory cases we use. Prazosin is unfortunately not available. Doxazosin is available, but that can be used. And the good side is that they control prostatic symptom if somebody is elderly and has symptom. And they are notorious to cause first dose hypertension, and they are also notorious to have this tachyphylaxis. With time, they tend to lose their effect. The last class of drug, thiazide-like diuretics, hydrochlorothiazide, chlorthalidone, and indapamide. Indapamide is slightly different. And then we have mineralocorticoid receptor antagonist, and spironolactone and allopurinol. So these are the drugs. Diuretics, they enjoyed being the first line for decades, especially in America. They still use this first line, but now they say it could be one of the many is the first line. Very useful in cardiac failure, and they make very, very good combination with other drugs, particularly RAS blocker, ACE inhibitors and ARBs. And then the downside is hypokalemia, hyponatremia, hypercalcemia, and diabetes and gout, but indapamide should not cause this because that is metabolically neutral. So I think these are some of the agents which we can use. In summary, the first thing is that patient with hypertension needs a detailed evaluation, not just a measure of blood pressure careful, but he needs to be examined thoroughly to determine his exact status and to have some idea about the prognosis. And the second is choose the best agent for the given individual from the available choices. I think our very learned speaker, Professor Shahbaz Qureshi, is going to tell us more about these agents. Thank you very much.
Thank you very much, sir, for the presentation. We got an overall idea about all the classes of different antihypertensive drugs and how compelling indications can help us choose a better antihypertensive tailored to the kind of patient who's presenting to us. Thank you so much for your presentation. I will move on to the next topic that's lined up for today, cut points of diagnosis and therapeutic goals. By Professor Dr. Tariq Wasim. He is Professor of Medicine at Akhtar Saeed Medical and Dental College, Lahore. Previously, he has been at Allama Iqbal Medical College and at Edinburgh Medical University. He is also the Senior President of Internal Medicine. Thank you, sir. Welcome. And please, you may start your presentation.
Okay. Assalamu alaikum. And I think my screen is shared.
Yes, sir. Yes.
Yes, so I'll be continuing on with where Aziz Sab left, and there will be a little bit of an overlap as well, because now we'll be talking about numbers and targets and goals. Right. The hypertension guidelines for the diagnosis, detection, and prevention and management treatment, they have been varying. The most of our recommendation would be based on the current recently published review by International Society of Hypertension in June this year. There has been a revision of these guidelines by American College of Cardiology and American Hypertension Associations. What we have been following, most of us, are the 2014 JNC 8 guidelines, which again have been recently in 2018. There has been a slight revision of that. And then, of course, American Society of Hypertension and European Society, and there are so many other Canadian societies which from time to time release their guidelines. And of course, guidelines are there to guide you. It is the individual choice and individual patient which has to be looked into. Again, this just various JNC reports which will came every 5 to 7 years. The first thing is, how do we define hypertension? Now, by definition, we define hypertension when someone has a systolic blood pressure of more than 139 and or a diastolic blood pressure of more than 89. And as Aziz mentioned very rightly, that based on it should be based on reading average of 2 properly taken measured readings and on each of the 2 or more office visits. The first question is your patient truly hypertensive, or you are just floating him up? The diagnosis and assessment of hypertension, again, just continuing on with Zisa was mentioned, that hypertension assessment has to address 4 issues. Is your patient? What is the individual's atherosclerotic cardiovascular risk score or coexisting cardiovascular risk factors? Is target organ damage present? Or are there any identifiable secondary causes? Again, as said, Aziz Sab has talked about this. Are you recording your patient blood pressure correctly? You had shown, and I'll just add on, the equipment is important. It should be validated every now and then. The operator needs to be trained. You just don't rely on your nurse reading or your technician's reading, and you have to be very properly train him. You have to use auscultatory method. In the newer digital meters. You need not to have a stethoscope even. But again, there is a talk about that there are wrist type of digital, say, BP recorders, and there are the cuff type. The one on the wrist are not as reliable. So if you are using a digital blood pressure recording apparatus, it should be preferably the one with the cuff. Again, the activities do affect the blood pressure reading. Once done with, you have to provide your patient with specific blood pressure numbers and the BP goals for the treatment we'll be talking about. The cuff should be covering at least 80% of the upper arm. While deflating, you probably have to lower the pressure in the cuff, not very rapidly and not very slowly. It should be a decline of around 2 to 3 millimeter per second. Patient should be sitting comfortably, back supported, legs uncrossed, upper arm barred, and arm should be at the heart level. And as is already told by Aziz Sab, that 2 measurements or at least 3 measurements in the second. Now, sometimes your systolic blood pressure can be inaccurately high if patient is fine, he's sitting with crossed legs, arm low, and it'll just show you the difference it can have. While you are talking, your exposure to cold, ingestional cold, it can have a variability of blood pressure ranging from erroneously low reading of 3 millimeter to as high as 17 to 13 millimeter of increase in blood pressure, particularly when you are talking, and you are talking particularly when you are talking politics. This figure is again already been shared by Aziz Sab, so I'll just skip that. The second question is that, does your patient has white coat effect? Is he truly hypertensive or not? And we do know that generally defined as that if your office BP is or clinic reading is more than out of office or home reading, we got it as a warning response or a white coat effect. The altering response causes an elevation blood pressure, and it can have such an effect up to almost 20 to 10 millimeter of mercury. The magnitude of this white coat phenomena varies if it is taken by the physician or in the older patients, or if they have a high baseline pressure. So for these patients, you probably have to rely on, if available, and on ambulatory blood pressure monitoring, or maybe home blood pressure monitoring to exclude this white coat effect. Again, a few words about this ambulatory blood pressure monitoring. It is warranted for the evaluation of white coat hypertension in the absence of target organ. If you find a patient for the first time or in office visit that he has hypertension, but there is no target organ damage evident from clinical examination as told by Aziz Sab, then you look for, recommend that the ambulatory blood pressure to be recording. The the general consensus is that the ambulatory blood pressure, awake patient, the blood pressure reading should be 130, less than average of more than 135/180, and during sleep it should be, if it is more than 120/75 during sleep or more than 135/85 during waking hour, you would be labeling that patient to be hypertensive. There is what we call the nocturnal dip. The blood pressure usually drops by 10 to 20% during night, and if this nocturnal dip is absent, even with the normal blood pressure, you consider these patients at high risk of for future cardiovascular events. The opposite of this white coat phenomena is also possible, that some people may have an office reading which is normal, but when they are at home, whether it be because of their wives or because of their other, say, things, their home reading may be high. Now, this is now called as a masked hypertension. This is opposite of that. There is a normal blood pressure reading in the office which is less than 140/90, but an elevated blood pressure. So in this, again, in this case, in an ambulatory recording of more than 135/85 would label that person to be hypertensive. This phenomenon can be seen almost 10% individual that they are hypertensive, yet not detected or yet not diagnosed, and it also definitely puts them at an increased risk and of cardiovascular disease as well as of target organ damage. The home blood pressure monitoring, if available, definitely gives you an not only that it helps you in detecting the white coat phenomena, but also response to antihypertensive therapy, improving the adherence to therapy, and then properly managing their hypertension. Then Aziza mentioned about that these patients who are hypertensive, they must be assessed for presence of atherosclerotic cardiovascular disease risks. So this is, I have taken a screenshot from an app which is available in App Store as well as other applications. And all you have to do is that you just put in these numbers over here, and it would calculate your risk of having cardiovascular event in next 10 years or so. And if the risk is more than 10%, definitely you are a high risk individual requiring an earlier intervention or earlier management. What does it translates into? Again, someone who has, say, no other risk factors and his blood pressure is in the high normal range, has a very low cardiovascular disease, as opposed to the one which is having multiple risk factors. There is hypertension, mediated organ damage, or there is CKD grade 3, or diabetes, or CVD risk of more than 10%. And along with this, then this column that is have a elevated blood pressure definitely is at definitely high risk of having cardiovascular morbidity and mortality. There are few situations where you call them hypertensive urgencies. Urgencies that when you're severely elevated blood pressure in the upper range of stage 2, we'll be talking these stages in a moment, and along without any end organ damage, you call it an urgency. And if it is more than 180 or 120 with progressive target organ damage, we call it as emergency. These emergencies can be in the form of either hypertensive encephalopathy or left ventricular failure or pulmonary edema, or they may present for the first time with an MI with this elevated blood pressure, or may end up with a dissecting aneurysm. So the second part of my talk would be when to label hypertension and what can someone stop this screen playing. That I can see a lot of sketches being drawn, someone on the screen. Right. So this is these are the 2020 International Society of Hypertension Global Hypertension Practice Guidelines. They were published in June 2020 in Journal Hypertension. The reference is there. You can consult them. So you diagnose blood pressure when there is office blood pressure measurement, at least 3 readings, and use the average of second and third reading. If the blood pressure is 130, less than 130/85, and you label that to be normotensive and remeasure after 3 years. And if there are cardiovascular risk factors present in that individual, you have to recheck within 1 year, even if with this blood pressure. On the other hand, if blood pressure is up to or more than 130/85, you confirm on for the 2 visits, or by home ambulatory recording, or by say self-monitoring. And if home BP is more than less than 130/85, 24 ambulatory reading is less than 135, you again remeasure this. So this the one who had less than 130/85, you are measuring after 1 year, and after 3 years, sorry, and with risk factor 1 year, and this after 1 year. But if this reading is home blood pressure reading or 24 average is more than 130/85, or nocturnal reading is more than 125/75, you label that person to be hypertension. The classification based on these BP reading is that you label someone to be normotensive is blood pressure systolic is less than 130 and diastolic is less than 85. This is the reading, the recommendation or classification by International Society of Hypertension, that after the normal, the second category is a high normal BP. I'll just show that how does it differ from JNC 8 classification of this group. This is the one with the blood pressure reading between 130 to 139 of systolic and or a diastolic reading between 85 to 89. So this class is called as a high normal blood pressure. Grade 1 hypertension is when you have a blood pressure systolic between 140 to 159 and diastolic between 90 to 99. And grade 2 hypertension when you have blood pressure systolic of more than 160 and or a diastolic blood pressure 180. So this just focus on this green line in this column and this JNC 8 categorization which was in now this group is 120 to 30. 120/80 was labeled as normal blood pressure, and this group was called as a pre-hypertension, and this word pre made a lot of individuals think that they are hypertensive or they may require a treatment or somehow. So that's why the ISH now has labeled it as high normal rather than calling it pre-hypertension, and the stage 2 and 1 and 2 are remain the same. The criteria again based on their office reading or ambulatory blood pressure monitoring or home blood pressure monitoring. So anything office reading of more than 140/90 would be called as hypertension. On ambulatory blood pressure monitoring, 24-hour average of more than 130 or more than 80 would be labeled hypertension. Daytime average or ambulatory recording of more than 135 and 85 again is hypertension, and nighttime average of more than 120/70 would be labeled as hypertension. And if you are relying on self-monitoring by the patient using home equipment, not 24 recording, the average of 3 or 4 readings, if it is more than 130/85, would be labeled as hypertension. Again, what do you do? So if your office BP is less than 130/85, you have to remeasure within 3 years or within 1 year if for those who have additional risk factors. If office BP is between up to 160/85, if possible, confirm without of office reading, either using ABMP or home monitoring, and alternately confirm on repeat visits within few weeks to months. But someone with a blood pressure of more than 160 systolic or more than 89 diastolic between to up to 100, this should be confirmed within few days to few weeks to decide the next course of action. Now, the initiation of treatment, of course, Shahbaz Qureshi sir would be talking it in much more details. It depends upon not only just the numbers. It also depends upon what is the degree of overall atherosclerotic cardiovascular disease risk, what is the level of sustained blood pressure increase, and of course, hypertension-mediated organ damage there or not there. Threshold for initial treatment as per JNC 8, that if there are no hypertension-mediated organ dysfunction or there is not much atherosclerotic cardiovascular disease risk. Anything above 140/90 after confirmation should be treated. With risk factors, without diabetes, or other than diabetes, again, the threshold remains the same. With the, say, evidence of, say, hypertension-mediated organ damage, again, blood pressure, the threshold to start treatment remains above 140/90. But there is some exception with some societies that with diabetes and disease, the threshold may be lowered to more than 130/80. The goals, what we want to achieve. Our goal by treating hypertension is to prevent cardiovascular events. Our goal is to the risk of this cardiovascular disease as starts even at normotensive individuals at 115/75 and as already mentioned by Somya, that increased with each increment of 20 millimeters systolic and 10 millimeter of diastolic blood pressure. Another emphasis which should be made is that the lowering of systolic blood pressure by 10 to 15 millimeter is associated with the reduction of coronary events and cardiovascular mortality by up to 1/3 by 5 years. So you need to emphasize to your patient that even if it is not going on to the normotensive level, a reduction of 10-15 from their baseline level, if it was very high, is definitely beneficial for them. Again, this is the same, that 115/70, you have a cardiovascular mortality of maybe normal individuals or normal population. At 135, it doubles. At 20 millimeter systolic, diastolic, 158, 4 times. And look at this figure. Your cardiovascular mortality goes up by 8 times if your blood pressure in the range of 170/105. What are the recommended BP targets that to which level would need to lower the blood pressure? Now, this is a summary of by so many of the say societies: JNC, British Hypertension Society, American Kidney Association, European Hypertension Society, Canadian Hypertension Society, National Kidney Foundation, and of course the International Society of Hypertension. The consensus is that in uncomplicated hypertension, your target should be less than 140/80. If your patient has diabetes or renal disease, target should be less than 130/80. And if there is renal failure already present or significant proteinuria, it should be less than 125/75. Again, as I said, there are some differences in this last two figures between ISH and this nephrology associations. Another group which needs attention is the elderly population, right? So those up to the 65-year of age, your target systolic pressure and with an average of 130 would be okay. But above 65, you have to individualize the treatment. You don't want to, there are some recommendation that it should be lower up to 150/90 and not less than that, but that is again depends upon patient's overall comorbidities, his life expectancy, his clinical judgment, the symptoms of hypotension which he suffers. So this is important. So our goal is to get to the goal, right? So we have to lower hypertension if it is hypertension alone to the level of around 140/90. But if there is diabetes or renal disease, you lower it up to 130/80. Measurements and goals should be provided to the patient. They should be told that this is your target of lowering blood pressure for you, considering your other risk factors as well. And of course, our subsequent speakers will be talking about the management through non-pharmacological measures, pharmacological measures and all that. But these are the numbers which we probably have to emphasize on your patients. Thank you very much. I'm over to Wafa.
Thank you very much, sir. I think it's very important to understand, as you have been telling us, who to treat and when to treat, and what your target is, what is it that you're working towards. So I think it was a very, very enlightening presentation. Thank you very much, sir. The next topic of presentation is non-pharmacological therapy of hypertension. It will be presented by Dr. Fibha Sayed. Dr. Fibha Sayed is Assistant Professor of Medicine at the Shaheed Zulfikar Ali Bhutto Medical University. She has had post-fellowship experience of 10 years with special interest in diabetes and endocrinology. We welcome you, ma'am. Over to you for your presentation.
Thank you very much for such a wonderful introduction. Let me just start sharing my screen.
Yeah.
Okay, I hope that it's visible.
Yes, ma'am, it is.
Okay. Thank you very much. I would like to thank the Pakistan Society of Internal Medicine for giving me this opportunity to talk about such an important topic, that is the non-pharmacological management of hypertension. All previous speakers have done a wonderful job, and they've set the bench quite high. So I hope that I can fill into the space that is provided to me now. So before we go on, let's talk about a few facts. Pakistan has a population of 21.2 million. 25% of our people live below the poverty line. The average monthly income is rupees 6,000, and yet 20% of our population is obese. We have the second highest per capita intake of trans fats, and we consume twice the recommended amount of sodium. 45% of our males smoke, and only 2 out of every 10 individuals meet the goals for proper exercise. So where we just earn 6,000 per month, I think it's important to say non-pharmacological measures would be extremely important where patients in the population can't afford drugs. So here is your chance to make a difference, and it costs nothing. So let me just go through the agenda for today's session. We're going to meet our first patient. This is going to be followed by a management plan. We'll talk about non-pharmacological management at a glimpse, followed by some deep diving into each intervention. And there'll be a few questions to assess yourself at the end. So I hope that all of you are paying attention to whatever is going on here right now. So let's talk about patient number 1. A 35-year-old male presents to you with a history of occasional headaches and palpitations. He is otherwise well and has no significant past medical or surgical history. There is a family history of hypertension. He smokes half a pack per day since the last 5 years and is on no regular medications. On examination, he's got a blood pressure of 140/90, which has been checked on 2 separate occasions, and his BMI is 28. Rest of the examination is unremarkable. So there are several points to ponder in this patient. Can we just start with non-pharmacological therapy? Should we institute drug therapy simultaneously? What can be obvious contributors in this patient? Any additional interventions which might be beneficial to this patient? And how long must the non-pharmacological measures continue? So this algorithm has been taken from the International Society of Hypertension, and here you can see that all the authorities would commence lifestyle advice immediately. However, if a patient presents to you with grade 2 hypertension, which is blood pressure of more than 160 systolic and 100 diastolic, you would require, in addition to lifestyle advice, immediate drug therapy. If a patient has grade 1 hypertension, which is a systolic blood pressure between 140 to 159 and a diastolic blood pressure of 90 to 99, we will then evaluate the patient for cardiovascular risks. And if he's got cardiovascular risks, he's got chronic kidney disease, diabetes, or hypertension-mediated end organ damage, then we start with drug therapy immediately, along with lifestyle modification. Anything short of this, we can give the patient a trial of lifestyle advice for 3 to 6 months and reassess. So coming back to our patient, what were the obvious contributors? There was the family history, which we can't do anything about. Unfortunately, we don't get to choose our families. Our patient smoked, and our patient had a raised BMI, especially for Asians. We're going to look at non-pharmacological measures at a glimpse. So non-pharmacological measures impacting blood pressure are salt reduction, healthy diet and healthy drinks, weight reduction, smoking cessation, regular physical activity, and stress reduction and mindfulness. So let's do some deep diving into each of these measures one by one. So why have I put this picture here? The lady and her child are from the tribe of Yanomami Indians. They live in Brazil and Venezuela, and the tribe is known to have one of the lowest blood pressures in the world. They have normal blood pressures are 91 to 64. There is zero incidence of hypertension, and there is no age-related rise in blood pressure. And why is that? Because their daily consumption of sodium is less than 180 milligrams per day. The only salt that they acquire is from the plant and the fruits that they eat. So yes, they have a primitive diet. Their diet has been the same since more than the last 100 years. But look at the impact it has on their blood pressure. So what can salt reduction do? We know that there's a strong relationship for salt intake and hypertension. We have a high capacity to survive at extremes of intake. So this population of Yanomami Indians, which takes less than 200 milligrams in 24 hours, to certain populations in northern Japan, which take up to 4,300 milligrams per day. But what is the RDA? The RDA, the recommended daily allowance, is 2,300 milligrams per day, and the AHA has a more stringent target of 1,500 milligrams per day. So would salt reduction have the same impact on everybody? No. The quantitative trait of salt-sensitive and salt-resistant individuals is that it's the ability of intake of salt to increase your blood pressure. And generally, the salt intake has a greater impact on people of color, in the older age, and in people who are hypertensive. So when you reduce your intake or your consumption of salt, it also improves your response to antihypertensive drugs, specifically ACE inhibitors and ARBs, because reduction of salt is actually going to increase your renin, increase your angiotensin and make you more responsive to this class of agents. And salt reduction, independent of all other factors, reduces proteinuria. The American estimates are that reducing salt by half, that is from 6 to 1 teaspoon to half a teaspoon, would have an economic benefit of around $10 billion per annum and reduce mortality by 94,000 per annum. So how much does the salt actually reduce your blood pressure? The highest is in African Americans, where you can see the systolic blood pressure comes down by 9.5, diastolic by 5.2, slightly lower in the non-African Americans. And the lowest part, look at the resistant hypertension, 22.7 fall in systolic and 9.1 in diastolic. So it's important to reinforce the concept of salt reduction at every visit the patient has with you in your clinic, not just the first visit. So what is the mechanism of salt-sensitive hypertension? So salt-sensitive in patients who are, it basically has to deal with the ability of your kidneys to excrete salt. Individuals who are salt sensitive with excessive salt intake there's a decrease in the aldosterone, and in salt sensitive individuals there's an upregulation of the mineralocorticoid receptor, which causes an elevation of the blood pressure. So let's contemplate the role of diet now. There have been a lot of diets in question, but most of the evidence comes from the DASH diet, which is the DASH diet trial, from the dietary approaches to stop hypertension. Diet rich in fruit, vegetables, legumes, non-fat dairy, whole grains, and low in snacks, meats, sweets, and saturated fat, along with low in sodium, will cause a reduction in blood pressure of 11.5 millimeters of mercury. Now, this is equivalent to a pharmacological intervention and is quite significant. Healthy drinks. There has been a lot of hue and cry around coffee, but generally, if you're not a coffee drinker, a single cup of coffee might raise your blood pressure acutely by 10 millimeters of mercury. However, in individuals who consume coffee regularly, it does not impact the blood pressure. More so, more than 3 cups of coffee a day will actually reduce your cardiovascular mortality by 15%. There's a positive linear association between alcohol consumption and the prevalence of hypertension and cardiovascular disease. Potassium. So again, low potassium intake increases blood pressure. More on this later, but taking higher quantities of potassium will actually cause a reduction in systolic by 5 and diastolic by 3 millimeters of mercury. Fish oil, again, very debatable subject, but generally, the doses in which fish oil is required to reduce blood pressure is 2.7 grams. Now, in these doses, fish oils will cause a tendency to bleed. They'll have a deleterious effect on your lipid profile and cause progression of chronic kidney disease. So the blood pressure effect is 2.51 to 1.6, but the higher doses are not recommended. High fiber diet, fish, magnesium, folate, good quantities will cause a reduction in systolic and diastolic by 1 millimeter of mercury. So this is more about the DASH diet. You can go through it individually later on as well from their website, but we'll go on from here because there are several other topics to get covered as well. So just a bit on potassium. The normal potassium requirement is 120 milliequivalents per day. Only 10% of males and 1% of females actually take this amount of potassium. And low potassium is directly related to raised blood pressure, risk of stroke, and chronic kidney disease. Low potassium through the WNK pathway actually causes increased or the upregulation of the sodium chloride co-transporter, resulting in increased absorption of sodium chloride and hence hypertension. And if you actually increase your potassium intake by 1.64 grams, there will be a reduced risk of stroke by 21%. So this has been talked about. So the recommendation is that patients who have hypertension and a normal renal function should maintain a high potassium intake through fruits and vegetables. And all of us know what the high potassium diet is. It's basically bananas, citrus, based on fruits and vegetables rich in potassium would be very helpful. So what about weight reduction? The mechanism by which weight causes hypertension is not clearly defined. However, it might be through several pathways, including sleep apnea, hyperinsulinemia, activation of the melanocortin pathway, causing increased sympathetic drive. A loss of 4 kilograms essentially would cause a reduction in the blood pressure by 6 millimeter of mercury. Okay, so what we require is a sustained weight loss. 6.8 kilograms of weight loss is associated with the relative risk of developing blood pressure by 22%. The rule of the thumb generally is that 1 millimeter of mercury would fall for 1 kilogram of weight loss. So the greater the weight you're able to lose, and we all know how difficult that is, the greater the amount of blood pressure you can actually bring down. Smoking cessation. So we all know that smoking is a major risk factor for cardiovascular disease, COPD, and cancer. It has an effect through increasing the sympathetic activity. The arterial stiffness caused by chronic cigarette smoking can actually persist for up to 10 years after you quit smoking. It's mostly seen in people who smoke more than 15 cigarettes a day. And immediately after you have taken a single cigarette, your blood pressure is going to spike by 20 millimeters of mercury within the first half an hour. So you're actually going to miss this effect if you don't check the blood pressure within the first 30 minutes. So cessation of smoking is essential for cardiovascular risk reduction by at least 30 to 40%. Coming to the effect of exercise. Now, we have several types of exercise, including aerobic dynamic, dynamic resistance, isometric resistance, but most of the data has been derived from aerobic dynamic exercise, which would include activities like walking, running, cycling, jogging, and swimming. And here you can see the striking impact that this meta-analysis of 27 RCTs shows that there's a reduction of systolic blood pressure by 10 and diastolic blood pressure by 4.7 millimeters of mercury, provided that these goals are met. 150 minutes of dynamic moderate intensity exercise per week, equivalent to 30 minutes, 5 times a week or more, or at least 75 minutes of vigorous intensity physical activity, which would be 30 minutes at least, 3 times per week. Lastly, stress reduction and mindfulness. There's a lot going on these topics, and if you haven't read about them already, it would be very helpful to take in meditation and mindfulness, make it a part of your everyday practice, because it does have an impact on your overall well-being and causes a reduction in blood pressure. So we'll just have a short self-assessment. There are 3 MCQs, and let's see if you can test yourself. So AB is a slender 60-year-old female, 5 feet 4 inches in height, 75 kilograms in weight, and she's diagnosed with stage 1 hypertension. Her blood pressure averages 135 to 85 right now, and she has no other comorbid conditions. She's otherwise in excellent health. What initial therapy would be most appropriate for this patient? Amlodipine, metoprolol, lifestyle modification, hydrochlorothiazide, or losartan? So the answer is lifestyle modification. This patient does not have any risk factors for cardiovascular disease. So we can give her 3 to 6 months with reassessment and ask her to pursue non-pharmacological measures first. Second question. A 45-year-old male presents to you with a history of hypertension since the last 3 weeks. His blood pressure recorded several times is in the range of 135 to 145 systolic, 80 to 85 diastolic. He's a smoker. He consumes alcohol. His BMI is 27, but he's enthusiastic about lifestyle changes. Which measure will reduce his blood pressure the most? Now, this is a very dicey question. Is it weight loss, regular exercise, dietary changes, smoking cessation, alcohol? We know that all these can impact blood pressure, and there are very close contenders here, but the answer is C. Dietary changes plus salt restriction can lead to a fall in 11 mm of mercury, followed very closely by exercise and very closely again by weight loss, provided that it is sustained. The last question of the day. A 55-year-old male presents to the outpatient department with a history of headaches since the last few days. He's got no comorbid conditions, and on examination, he has got a raised blood pressure 140/90. He says that he's recently consumed lots of salty diet. Which of the following statements about salt consumption is correct? A, the AHA recommends 2300 milligrams of sodium per day. B, reducing salt intake independently reduces proteinuria. C, salt reduction reduces blood pressure in all individuals. D, reducing salt intakes makes potassium supplementation more effective. And lastly, younger individuals have a greater impact on blood pressure with salt restriction. So the answer is B. So the AHA recommends 1500 milligrams. Salt reduction generally helps salt-sensitive individuals. Potassium supplementation doesn't work as well if the individual already has a reduced salt intake. And the effect of blood pressure with salt is mostly, it increases as the age increases. So with this, I would like to wish you all a happy Independence Day. And I hope that you will choose to make a difference with non-pharmacological measures. Thank you very much for listening to me.
Thank you very much, ma'am, for such a beautiful, concise presentation. And it has been very informative for all of us, because usually we would focus more on just, sodium reduction, and we don't probably stress on all the other more important lifestyle modifications that can cause such a considerable drop in systolic and diastolic blood pressure. We do thank you very much.
Thank you very much.
Our last topic for the day, the treatment algorithms with emphasis on guidelines by International Society of Hypertension. It would be presented by respected Professor Shehbaz Qureshi. He is the Professor of Cardiology, Consultant Interventional Cardiologist, formerly Head of Department, Federal Government Postgraduate Medical Institute. He is Professor of Cardiology, Head of Department, MBBS Medical College, Mirpur, Azad Kashmir. And presently, he is the Professor of Cardiology, Wateem Medical College, Islamabad. Sir, thank you for joining us, and you may take over.
Thank you very much. It's been an honor to be here with you today and to listen to such starting from the beginning in from the incidence of hypertension, and then on to the targets and the how to do the non-pharmacological treatment of it, and finally, important topic, and that is the drug. All right, can you hear me, please?
Yes,
Yes,
yes, please go ahead.
I think there was a disconnection,
Yeah.
and because of that, we had to stop in between.
Yeah.
But what I'm going to do is basically talk to you about the drug treatment of hypertension. And I'm going to try to make it as simple as possible, because I don't want you to be actually engrossed into many guidelines, because guidelines are there for us to actually guide us, but they're not the ones who determine how we treat these patients. What we really need to do is to treat our patients appropriately and adequately. Now, why do we treat our patients? That is very important. And this is one of the studies which has been published a long time ago, which showed we always have been talking about the effect of blood pressure and the incidence of intracranial hemorrhage or other CVAs which occur in these patients. But we forget that the most important determinant of increased blood pressure or the systolic blood pressure or the result of that on the brain is dementia. It is the loss of cognitive function that is there. And that is what we actually have to keep in mind when we are treating a patient with hypertension. And if we treat them properly, we are actually going to reduce, as you can see here, the incidence of dementia and the improvement in cognitive function. So keep that in mind as to why we are advocating treating blood pressure. That is extremely important, because we need to tell our patients why we are treating them. You've already heard about it, but non-pharmacological treatment actually has shown a reduction in blood pressure. Here, for example, in this particular study, a very important one, where the decrease in salt intake reduced the incidence of blood pressure. And in decrease in weight also reduced the incidence of blood pressure. Even a modest level of aerobic exercise can lower blood pressure. And you can see that happening. This is the evidence that we have from studies that with the reduction of weight, with the reduction in salt, with a modest amount of aerobic exercise. Sometimes I do not even advocate strenuous exercise. You can keep on walking. If you walk, you increase your circulation to the brain. If you walk, you increase the circulation to the heart. If you walk, you increase the circulation into the legs. You reduce your blood pressure, and that is extremely important. Now, this is a very good study which was carried out sometimes in the late 60s and the early 70s, from where it was determined whether we should treat our patients with drugs or not. And this was the Veterans Administration cooperative study, which showed that in those patients who were treated with drugs, and mind you, even at that time, they were treated by combination of drugs. And the combination was of hydrochlorothiazide, reserpine, and hydralazine. And it showed that there was a reduction in blood pressure. This is from where we determined that if you reduce the blood pressure, you will reduce the incidence of cardiovascular events in your patients. And that you will have to manage them as has been shown in this study, and not by individual likes and dislikes. Then another important point, which we all must keep in mind, is that in most of our patients, and this is actually another study, a prospective study, which perhaps would never be repeated, at least in our lifetime, where those individuals who had no morning rise in blood pressure and those who had a morning rise in blood pressure. And these individuals, you can see that those who had a rise in morning blood pressure, there was an increased incidence of silent cerebrovascular infarct at baseline, and also a clinical stroke during a 41-month period study follow-up. So the early morning surge is the one which we have to keep in mind. And this actually correlates with cardiovascular events. And therefore, when you manage these patients, you need to manage them in a way that you overcome the morning surge of blood pressure. That is the pharmacological aspect to it, how you treat it adequately and how you treat it for the 24 hours. It is not for 6 hours, it is not for 8 hours, not for 12 hours, but continuously for 24 hours. There are various guidelines which we have all been reading about, and I think Professor Ishaq is here. We have bbeen talking about the JNC7, the JNC8. For God knows how many years we have been talking about pre-hypertension, and we then did away with that name because I thought that it was also not appropriate, because that meant the person was already hypertensive. Now, these guidelines, the American College of Cardiology and the American Heart Association guidelines, they define normal blood pressure, and the stages of hypertension, they're different. Then they have a high normal blood pressure category. What they've done is they did away with the pre-hypertension and they brought in another category, the high normal blood pressure. Then you have the blood pressure value thresholds for treatment are therefore different in different guidelines. Now, what has ISH actually done? ISH has divided the management into two groups, and I somehow have a little difference of opinion here. The guideline people who write them, they work very hard. They put in hours and weeks, months of their effort into it. They actually cover a lot of papers, thousands of them, and then they come up with the guidelines. But there are certain differences, or we can actually criticize them. And I think it is important to criticize the guidelines as well. What they mean about essential is that whenever we are talking about guidelines, we know that the American College of Cardiology guidelines are from the United States of America. The European Society of Cardiology guidelines are from Europe. And when we look at the incidence of hypertension, the incidence of hypertension in those countries is not so high. The incidence is the highest in our part of the world. Dr. Iqtidar talked about the incidence of 1.40 billion people who are hypertensive. But do we know that 1.03 billion are in the low income and the middle income countries? And therefore the guidelines have to be tailored according to our situation. And that is important. And that is what ISH tried to do. And that is what, when we talk about essential, according to the ISH guidelines, but I'll talk about why I have a little criticism. Essential means that the bare minimum that you can do for your patients who cannot afford. Even in the high income countries or even in the high income areas, you have those individuals who still cannot afford. And so the bare minimum that you can do for your patients. And then the optimal, which all guidelines actually advocate. And this is the essential difference between the previous guidelines and the new guidelines. But remember, as I said in the beginning, guidelines are only there to guide us. We need to control the blood pressure. Whatever we do, we must control it. And that is what I'm going to talk about. The international guidelines, this is what they're doing here. They talk about the high normal. But you see, Dr. Tariq also mentioned about the targets of blood pressure, and he said 130/80. And here, the normal blood pressure, which is being set by the ISH, is 130/85. So I think we need to actually look at it critically. This is the high normal blood pressure, which we see here. The grade 1 hypertension, 140 to 159, 90 to 99 diastolic, and the grade 2 hypertension. And in the ACC guidelines, they are far more stringent in it. They actually bring the blood pressure down to 120, less than 120 to less than 80. Perhaps it may be good for our part of the world, because the Asians, of which area we are a part, actually have a higher incidence of hypertension. And then we also have a higher incidence of cardiometabolic syndrome. And therefore, perhaps bringing our blood pressure down to lower limits is even better. So if we keep that in mind, but if I can bring the blood pressure down to less than 140/90, what I always say is that let us put the ball in the good length area. And that is important. We should not actually be obsessed by numbers, that this from less than 140/90, and the range starts from 120 to 70. Never bring the blood pressure down to less than 120/70. That is how I feel. When we look at the ESH guidelines, which came in 2018, and the ISH guidelines of 2020, you can see that the target population is the same. The focus is on optimal care, but here in the ISH, there's a difference from the optimal care when possible and essential care as a minimum. But I'm sure each one of us realizes that when we are treating our patients, we do not make a difference. That this patient for whom a blood pressure of 170, 90 or 100 will be all right. And if we bring it down to 150, 90, it's okay for this patient. No, it is not okay. You have to bring it down to the level which is the target. Then the classification, there was no change. We still believe that hypertension is when the blood pressure is 140/90 and above in ESC, and hypertension is 140 and above by 90 above by the ISH guidelines. The diagnosis here, as was pointed out earlier, you can use the office blood pressure, the home blood pressure monitoring, or the repeated blood pressure. However, in the ISH, same for optimal, it is the same, but for essential, because of the resources which are limited or constrained, then possibly you don't do ambulatory blood pressure monitoring or home blood pressure monitoring. But if I ask all the people or all the participants who are listening to the presentations today, how many of us actually do the ABPM or the home blood? Home ABPM is not there. It's not there so much. We have to rely on the office blood pressure recording. Once we make a diagnosis of hypertension, that is the most important thing. Cardiovascular risk assessment, ESC says you make that assessment. ISH says that you can do it for optimal, but they don't have a tool there. And let me ask each one of us who is sitting here that how many of us actually do the atherosclerotic cardiovascular disease risk assessment? There were about 500 doctors sitting in an audience, and I closed my eyes and I asked them, please raise your hands as to how many of you do this, the risk scoring, and there were hardly 10 who raised their hands. So I think let's not get bogged down with this. Then the drug treatment is very simple. I think it is the lifestyle is first and foremost. It is of paramount importance to institute lifestyle management in our patients. And what does that mean? Sit down with the patient, spend time with the patient, tell him what to do, tell her what to do, and see on every return visit, does that patient do it or not? And then when you have a grade 1 hypertension in high risk, drug treatment is mentioned here. And in the low risk, which after 3 to 6 months in the ESC, it is nearly the same. But in essential, what they say is focus on grade 2 and high risk grade 1 if resources are limited. But my dear friends, would we make a selective management of a patient? Would we say this is the patient who needs an optimal care and this is the patient who needs an essential? Because suppose a person has a blood pressure of 200 by 110 and the essential says reduce it by 20 by 10. What will be the blood pressure? 180 by 100. You think that you will reduce the incidence of cardiovascular events in this patient? No, you will not. So you will have to bring the blood pressure down in these patients. And that is what my criticism is. Lifestyle intervention, you've heard it in detail, very important. Meditation and air pollution. You avoid stress. You do whatever you do, reduce the stress. And what I see now on most of the prescriptions is, and the last what is mentioned is 5 times prayer. It is very good. Let us have it in the number first place. Meditation is important and that will bring down the blood pressure. A healthy activity, that will bring down the blood pressure. And when we talk of lifestyle intervention, I think, ladies and gentlemen, it is very important that it should be a family get-together. The family that plays together, gels together. They have a very good approach towards life. The initial drug therapy, Dr. Aziz earlier on mentioned about it. I have been speaking about a single pill combination for a long time, and I'm so glad that the European Society of Cardiology incorporated it, and now the ISH also has. Here, for example, in the ESC guideline, we have usually the A plus C or A plus D, where A stands for ACE or ARB. It is not that ACE is first or ARB is first, and then it is the calcium channel blocker and the diuretic here. And wherever indicated, beta blockers. In the optimal therapy here, same, A plus C, a single pill combination. In those black patients, you use calcium channel blocker and a diuretic. So you have to actually see, according to your requirement, what you are doing for your patient. Then you have to monitor your patient. And then I think it's important that aim for blood pressure control within 3 months. Don't wait. Early treatment is important because that is how you're going to reduce the incidence of cardiovascular mortality, of stroke, of myocardial infarction. And the earlier you treat them, one of the slides which is often repeated is that there is a blood pressure of 115 to 75. And when that, I think Tarek showed it to us. And as you increase it and you go to the highest limit, it is 8 times what it is. I used to think about it and I have come to the conclusion what it really means is that if I am today 115 by 75, after some years my blood pressure is going to increase. That is for sure. And therefore, if there will be an increased incidence of events in those individuals when the blood pressure increases, control the blood pressure early. Then you have statins in the ESC. It's very important to give statins to your patients, but there are no specific recommendations as far as the ISH is concerned. Now, the target, remember, is 140 by 90, less than that. That is where your blood pressure should be. That is where my blood pressure should be. If I am being treated by somebody, I want my blood pressure to be less than 140/90. at the ideal range of 130/80. That is where it should be. Tariq talked about the elderly patient. I think it is important because those patients who are fit 80, they are different. The frail fit 80 are different. So you have to treat them accordingly. And whenever you are measuring the blood pressure, I was taught by my mentor and teacher, Dr. Shaukat Malik, that always take a standing blood pressure. See for postural hypotension. So I'm sure all of you who have gone through your studies in medical colleges and trainings, they all know these things, but I'm just re-emphasizing postural hypotension, extremely important. If I do go a little off time, please allow me a couple of minutes. I think Aziz can do that for the sake of my seniority.
Yeah, that's right.
When you have actually an established diagnosis of hypertension, whatever you do, once you have diagnosed that the patient is hypertensive, then it is lifestyle advice. And if you have done the maximum to give them the proper advice, after that, you have two categories. You have the grade 1, which is 140 to 159 and 90 to 99. And the grade 2, which is more than 160 to 100. In this category, if you have patients who are high risk or those with cardiovascular disease, chronic kidney disease, diabetes, or hypertension-mediated organ damage, as Dr. Aziz mentioned, these are the ones who come over to this side and need immediate drug treatment. Those who have more than 160 to 100, they need immediate drug treatment. Now here, there's another category which will go into the essential side of this algorithm. And it will, if there's a limited drug availability, then if it is yes, then you will try to have a lifestyle intervention for a longer period of time and then see if you can bring down the blood pressure. But then, as I said earlier on, you cannot wait that long. You have to realize that these patients also are going to develop hypertension-mediated organ damage. So I think treat them early. Now, for example, here it is said in the essential target blood pressure by at least 2010 and ideally to less than 140 by 90, and that is the aim for blood pressure control within 3 months. Just imagine, as I said earlier on, your patient has 180 by 110. You bring it down to 170 or 100. Don't you think this patient still needs more treatment? So I think that is where they have done a good job, no doubt about it, but I think we need to really see our patients according to what we are going to do for them, how we are going to prevent the events in them. In the optimal, simple, less than 65, bring the patient down to less than 130 by 80, if tolerated, but never less than 120 by 70. Extremely important. If they're more than 65, it's very good. They've raised the target to less than 140 by 90, if tolerated. But consider an individual, as Tariq pointed out, for the blood pressure target in the context of frailty, independence, and likely tolerability of treatment. This is extremely important. So that is how you're going to tailor-make your treatment to your patients. Let us now come to the drug therapy. And I think it is very, very good. This is what should be done. In step 1, ideally a single pill combination, go with a low dose combination. This is the optimal site. And go with a low dose combination, and that should be an ACE or an ARB and a calcium channel blocker. There are certain footnotes here. For example, consider a monotherapy in low risk grade 1 hypertension in very old, over 80 years. Consider ACE inhibitors or ARBs and diuretic in post-stroke, very elderly, incipient heart failure or calcium channel intolerated patients. And I remember in these very elderly patients and the stroke patients, Professor Javed Akram did a very good study with indapamide in the HIVET study, and there's evidence for us there. And then consider A plus C or C plus D in black patients. So this is step one. Your patient still in blood is hypertensive. Go to step two, which is the dual full dose combination. And if still the blood pressure is not controlled, use a diuretic. What is recommended is a drug which is chlorthalidone or chlorthalidone equivalent, like indapamide. It is not a thiazide here. It is basically a chlorthalidone. But if, for example, it is not available, then you use a thiazide in these patients. If despite this third step, you have given 3 drugs and the patient is still hypertensive, then you need to actually add a drug like spironolactone. What I find normally is that some of my patients with spironolactone, they develop gynecomastia. And therefore, I put them on a drug like eplerenone. And by and large, 12.5 to 50 milligram is really good. Then if you come onto this arm, the essential treatment, use whatever drugs are available. For example, I find a number of patients being treated on beta blockers. The blood pressure is controlled. They cannot afford any other drug. So why not just continue with that? Use free combinations. You can do that in these patients. Thiazide diuretics, because they are cheaper also. And then if you cannot use calcium channel, the dihydropyridine calcium channel blockers, or if they are not available or not tolerated, then use the non-dihydropyridine calcium channel blockers like diltiazem or verapamil. And here, for example, in essential or optimal, consider beta blockers at any treatment step when there is a specific indication for their use, like heart failure, angina, post-MI, atrial fibrillation, or younger women in whom the circulation is hyperdynamic with or planning pregnancy. So these are the drugs that you have before you, the armamentarium, and you can use them. Now look at the ideal drug characteristics. Treatment should be evidence-based in relation to morbidity and mortality. Prevention, that is what we are tuned in to do. That is what our goal is. We should use once a day dosage because the compliance will be better. The treatment should be affordable and cost effective relative to other agents. That is extremely important because patients should be able to afford it. If they can't afford it, they won't take it. And if they don't take it, their blood pressure won't come down. BP will only come down if they take their drugs. And the drugs should be well tolerated. If you have a young patient who is hypertensive, married individual, and you give him certain drugs, he develops erectile dysfunction, he's not going to forgive you. I think it is important that the treatment should be well tolerated. Evidence of benefits of use of the medication in population in which it is being applied, extremely important. Black patients, different. And I find there are certain differences also which occur in our part of the population because I'm sure Dr. Aziz, Dr. Tariq, they see more of these patients with cardiometabolic syndrome. In Pakistan, for example, there's a very high incidence, and that is what you need to keep in mind when you're treating your patients. So in summary, ladies and gentlemen, in established hypertension, uncontrolled by lifestyle measures. So this is very important. Don't forget lifestyle measures. Drug threshold more than 140/90 and raise it to 160 or 100 millimeters for those at low risk patients, which means that if somebody doesn't have a hypertension mediated organ damage, you can actually increase it. But I find that also increases the incidence of cardiovascular events in the future. So I want the target to be less than 140/90. For less than 160, 130/80. Here, for example, it says that, and I showed it to you earlier on, that it was saying 130 to 85. So there are certain discrepancies. Then when the age is over 65 years, it is less than 140/90. Essentially, here is where I differ in it. I still wanted the blood pressure Either you are using in the essential group, reduce it to less than 140/90. Use the cheapest medicines possible. Make sure that lifestyle measures are adopted. The blood pressure will come down, inshallah, in these patients. So the drug up titration to target of the following: low dose angiotensin converting enzyme inhibitors or blockers plus calcium. Go to full dose, add a diuretic, add a spironolactone, and consider other initial combinations for specific patient subgroups. Use single pill combinations whenever it is possible, and use thiazide-like diuretics preferentially. They are important, cheaper, and where less ideal agents are available, but still bring the blood pressure. If it is still high, more than 140/90, even those who cannot afford it, do something. Get their blood pressure down. Now, this is a very important summary slide which I have. We have so all the trains are actually coming or converging towards the same destination, and the destination is a target of less than 140/90. Whether it is the ISH 2020, the PHL Pakistan Hypertension Guideline, the ACC AHA guideline, or the ESH guideline. All these paths, you board any train, all the doctors are very well qualified. They have attained their degrees. They are trained to manage these patients. You get onto any train, get any ticket for the train, but reach the destination. And my friends, the destination is less than 140/90. Please do not worry about the guidelines. Once you establish the diagnosis of blood pressure of more than 140/90, reduce that blood pressure. Do whatever you can. And the bottom line, which I have for you, is that the common denominator to all the hypertension guidelines is initiate the drug treatment of hypertension with combination therapy and not monotherapy. If you will do that with a low dose, go to the higher doses, combine different drugs, you will be able to achieve the target. And remember, in Pakistan, the population is less than 65 years. They need your help. Reduce their blood pressure. You will reduce the incidence of cardiovascular mortality, of stroke, of myocardial infarction, of disability, and the effect that it has on the families. God bless you all. Stay safe and stay blessed. Thank you very much.
Thank you, sir, for this very enlightening, very informative presentation. Definitely, as you say, it's important to understand your patient, to sit with him and to spend some time, and you would be treating his blood pressure better.